Welcome to KSC 2017, the wrap-up interview number 3. It's great honor for me to have the 3 distinguished speakers, the scientists in this field. Today we like to discuss of the frontiers, the cardiology, especially the future technology and the future of the diagnosis and therapy. So I'd like to introduce first the speaker is the Dr. Raj Khandwala from the Cedars-Sinai Medical Center, Los Angeles. And the second is the Professor Ian Ashley from the Stanford University, the United States. And the last speaker is the Xian Chen from the Taipei Veteran General Hospital, I think worldwide well-known electrophysiologist and that's right. Okay. So today we had a very exciting session on the future cardiology evolving and I think emerging the issue. So the first time I'd like to ask the Professor Raj Khandwala about the heart failure program, the remote monitoring heart failure. So would you introduce the congestive heart failure program in the Cedars-Sinai?
So what we've done is we've taken a multidisciplinary approach to being able to reduce heart failure admissions, an approach that involves cardiologists moving services from the hospital to the clinic, and then also employing remote monitoring to be able to monitor patients at home. The remote monitoring aspects are clearly in their infancy, but what we've sought to do is run clinical trials to be able to better understand the heart failure phenotype in patients' homes, whether that be with wearable sensors that can pick up patients' fluid status, but also using wearable monitors to see their patients' activity at home.
I see. So that's the multidisciplinary approach, especially heart failure. So I have one patient who had the heart failure, but the patient has the CLTD. The patient actually, he died and on the way to come to the hospital. So in Korea, the remote monitoring is not yet available.
Yeah.
So we are very sad, and we the suffering to I think they implemented this new technology. So how the new technology, especially wearable or some other the necklace or other the new equipment for the remote monitoring the heart failure?
Well, I think there's a number of different companies that are trying to devise wearable devices that can, monitor people at home. And, what we need to do is better understand what these patients are doing at home. How their clinical status is changing over time, because most of the time is not spent at the hospital, nor is it spent in the clinic. It's spent at home. And so now that increasingly people's homes are connected to Wi-Fi networks and cellular networks, we should be able to pick up early signs of decompensation. That decompensation doesn't just happen days before people are hospitalized; it happens weeks before people are hospitalized, and there's an increase in filling pressures. The CardioMEMS device is the first to be able to show that if you measure intracardiac pressures remotely, that you can reduce heart failure admissions. We should be able to come up with devices that don't need to be implanted, but also can be wearable devices that can capture similar type data.
I see. And also in your talk, I'm very impressed that you're the ultrasound and the measure of the IVC to predict the heart failure in advance. So would you introduce the use of the held-on the ultrasound for the heart failure?
Yeah, our team identified that one of the reasons why patients were being admitted to the hospital was that we didn't have an accurate assessment of volume status, and physical exam really was letting us down. So what we did was we started to use handheld ultrasound. In this case, we used the GEV scan device to be able to image the heart during clinic visits and also image the IVC, the inferior vena cava. Inferior vena cava has been known, its diameter has been known to correlate with right atrial pressures. And what we were able to show was that an increased IVC diameter was associated with increased risk of heart failure admission. So this is a cheap tool, a relatively inexpensive tool that can give us a better assessment of volume status. We also use the IVC to identify patients' ejection fraction, if they had functional mitral regurgitation, if they had pleural effusions that were transudative due to heart failure, we drained them to be able to keep them to the hospital. So this is just another tool in order to be able to assess those patients who are at high risk of being admitted to the hospital.
I see. Okay, great. So I'm wondering, do you have some plan to do this program and the equipment, the detection of the heart failure aggravation? You know, the bands that has not only the hospitalization, also some mortality benefit by doing the prospective study. Or so, would you introduce your plan?
Yeah, so I mean, we have plans to do a randomized controlled trial using the handheld ultrasound to standard care to be able to see if using the handheld ultrasound is a cost-effective way to be able to reduce heart failure admission. We hope that over time that it will actually also decrease mortality as well. A lot of the remote monitoring trials in heart failure, however, right now are powered towards decreasing heart failure admission, and we'll need larger studies to be able to look to see if they actually decrease mortality.
Great, thank you very much. So at the end, we like to discuss with the three distinguished speakers as well. So, Professor Ashley, I'm very impressed among your talk of the gene, the sequencing and gene testing in the cardiovascular disease. So would you introduce firstly the gene testing, the discovery in the cardiovascular disease first?
Yeah, very happy to do that, and it's really great to be here. I think that we've known for really a long time that certain inherited cardiovascular diseases clearly run in families. And this is not the way that coronary artery disease or high blood pressure diabetes run in families, where in general we see it more often in some families than others. But these conditions that we know are caused by single gene or single variants. And we learned that in the much more recent past, the last 10 or 20 years, but we've probably known for 100 years, even 150 years, for certain conditions like long QT syndrome or hypertrophic cardiomyopathy, that there are very clear patterns where within a family, certain individuals get the disease. It might take many decades, but they will eventually get the disease, and other members of the family simply don't get it. And that was always suggestive of the idea that a certain single gene or single gene variant caused that condition, and you either inherited it or you did not. But it really took many years into the 1990s before we really understood that by studying very large pedigrees and starting to use the genomic technology that came along with molecular biology revolution to really understand what those genes were and what their effect was on the DNA of the individuals within the families.
So we are actually facing the cost of the gene test, and always the higher cost, and the patient cannot afford, and most of them. And so, but in your slide, I found that the cost is dramatically decreased in after 2014 or 15. So would you introduce what caused of the cost reduction?
Yeah, it's very exciting. It's really a complete shift in the technology that we've used for sequencing DNA. And in the earlier days, what we would do is amplify a particular section of the DNA, and then we would spell out each letter. And that was a very longhand way of doing this. But what happened in, as you mentioned, the late 2000s, the early 2010 and onwards, was there was a dramatic decrease in the cost of sequencing, and that was secondary to really an upscaling of how many DNA molecules we could read at one time, from a few hundred of one specific area of the genome to billions of DNA molecules that would come from all parts of the genome. And what that meant was the initial Human Genome Project, which was a project that took 10 years and was funded at $3 billion, and then the second genome that cost $100 million, were left really in the dust as the price plummeted dramatically towards $1,000 for a whole genome. And that's what we have now. And the technology has moved so quickly that we've really been in a situation where two technologies are coexisting. The old technology, where we would look at one gene at a time and we'd spell out the letters, and that for a genetic test using that technology might take 6 weeks and might cost $5,000, while at the same time we can do a genetic test where we can sequence the whole genome as 20,000 genes, and those 20,000 genes only represent 2% of the whole genome, so they're 98% of the genome.
Right.
The rest of the non-genic genome We can get all of that for 1,000. So it's kind of a very unusual situation where the technology has moved so fast, we're in a whole different world.
I see. Would you introduce, now we are the most of the scientists and medical doctor also is interested how incorporate the AI, the artificial intelligence with the gene, also the precision approach for those of some genetically determined cardiovascular or arrhythmia or whatever the disease. So would you introduce the future of the AI incorporating with the gene analysis and the gene discovery?
Yeah, that's a really good question. And of course, these are two areas of really great excitement. And first of all, the ability to generate large-scale data through genome sequencing technologies. And then the ability of computational power and storage to be able to keep up. The algorithms or the computer methods for looking at that large-scale data come under many categories. And artificial intelligence as a general category is one of them. And what it relies on in most situations is the ability to train an algorithm. So if an algorithm can learn usually from classified data, what kind of patterns there are that are being picked up. A good example is on Facebook or on Google now, you can look at images that have been classified. This is a dog, this is a frisbee, this is the beach. And they can start to do that on pictures that they've never seen before. Not because we've said, well, sand is brown and it's often next to a blue sea, but rather because the computer has found its own patterns in the data. Now, if we take that technology and apply it to genomes, we have this very deep-rooted ability to look sort of beyond the obvious and to look into multiple dimensions to try and just be smarter at using the genome to predict who's going to get disease, who's going to get severe disease, and in the best possible world, what treatment we should give those individuals. And that's really the essence of precision medicine, taking a disease process and subtyping it using molecular tools, artificial intelligence, other tools, in order that we can treat those subtypes, subgroups of patients much more precisely and better.
Yes. So I like to give the little bit more challenging the question. For example, the Brugada syndrome. Brugada syndrome has some patient has the ICD. About the ICD inappropriate shock, usually due to the atrial fibrillation. Okay. So in that case, if we detect atrial fibrillation high the risk of the AF by the gene, I wish we can do the pulmonary vein isolation prophylactically.
Yeah.
And as you mentioned, the AF management, the hypertrophic cardiomyopathy, which patient is the most likely to develop AF during the follow-up. So that's the precision medicine with the gene sequencing, based. I think that's going to be one of the future. So what do you think?
Yeah, I think that's a great point. And I really agree that this is the future. If we start to understand patients' baseline better, because we can sequence their genome, we understand their disease, they don't just have hypertrophic cardiomyopathy, a thick heart, but they have this particular form that's caused by this particular gene that leads to a particular set of symptoms or signs earlier than if you have a different form. So that's the baseline understanding. But then we can use these self-monitoring methods, and it might be an implantable defibrillator, it might be a wearable, as Dr. Khanawal mentioned, but there are many different data streams that can be brought in. If we can combine knowledge of the whole community together with specific knowledge from that individual, because the device knows what it's like on a Monday and on a Tuesday, and if things change on a Wednesday towards, say, a rhythm of atrial fibrillation, then it will know that. And use all that information to make a much more intelligent guess, a much more intelligent prediction as to whether that shock should be delivered.
Great. So I'd like to ask the Professor Xian Chen, and who is the well-known electrophysiologist. So you show us the development of the future of the three-dimensional electroanatomical mapping system. So what your future perspective of 3D mapping in the diagnosis and the specific the guide in the ablation or other therapy?
From my point of view, I think the faster and accurate diagnosis of the cardiasmia it is fundamental of the 3D mapping tool. And I think it maybe in a recent 2 years, it's a lot of significant improvements. Like today I mentioned about the Pentale and A2 double dual decapolar catheter and also the Ornia catheter. Those are based on the high density mapping. I think it improvements for our understanding of the substrate property. We already have a lot of improvement.
I see.
The other one is I talk today about the irrigated catheter, how to increase the penetration and the transmural region. It is also important for the cure of those arrhythmia. For example, we just mentioned about hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy with ventricular tachycardia, it is very tough for the cure it. You can use the more powerful irrigation catheter to make a transmural region, or you need a bipolar ablation from the endocardia and the epicardial bipolar ablation. Those are challenge to the hypertrophic cardiomyopathy. So that's another question is from our NGS screen of the hypertrophic cardiomyopathy, we may identify which type of genetic mutation the patient can have ventricular tachycardia, or which type of patient can have atrial fibrillation in a long-term follow-up. I think it's very important because some patients with a very severe hypertrophic cardiomyopathy, but with very rare ventricular premature beat.
Right.
Those patients did not show a ventricular tachycardia, only show the outward trait obstruction, but no ventricular arrhythmia. It's quite intriguing for us. But maybe from the genetic testing, we can understand how is the overlap between a ventricular tachycardia and the hypertrophic cardiomyopathy. Also, another question is, Yang Hong, you just mentioned about the atrial fibrillation with hypertrophic cardiomyopathy. Because in previous years, we only mentioned about the increase of left atrial pressure would induce atrial fibrillation in the hypertrophic cardiomyopathy patients. That's only from the atrial size and the atrial pressure. But besides those mechanisms, I think maybe a genetic testing is important for those patients. That's just my point of view.
Yeah. I think as you mentioned, especially in the EP field, we are very exciting to incorporate it. The many gene tests, the NGS, and unmask the ventricular arrhythmia, atrial arrhythmia as well, and also we have some tool, the imaging, and also incorporate the cardiac MRI and other imaging in our 3D mapping. But as Xian Chen today you mentioned, the mapping is I think in the electrodes, the resolution should be very high, in the 1 or 2 millimeter, and also the size also very important, and multi-electrode to see the global assessment at once, right? So that's incorporate with the other imaging. That's going to be the key to the high resolution mapping system, right? So what do you think in the classical, for example, entrainment mapping or the classical mapping system? Do you still use the classical or so would you introduce your current the practice?
I think that currently we still use a classical and the advanced mapping technique together. For example, intramural mapping, activation mapping, and the substrate mapping. But the problem I'm thinking about because cath ablation success rate for the atrial arrhythmia or the ventricular arrhythmia, even in the recent 5 years, it's not so much improvement.
Right.
For example, atrial fibrillation, the 1 year free or atrial fibrillation average or around 75% or 80%. So that's why we needed to think about the other method. For example, decrease of the body weight and the improvement of sleep apnea or any other way, we can try to think about it. And my point of view, if we can use big data and also we can use artificial intelligence, including genetic testing, then we can cut down our medical cost for those patients. Otherwise, every patient receives so intensive testing and treatment, but still have atrial fibrillation recurrence, still have a sudden cardiac death.
Yeah.
That's my view.
I think it's a good point, and we experienced while I'm ablating. This patient should identify before bring to the table. This patient, it's better to send the surgical first, or just the area appendage resection first, or just the rate control with the drugs. because some patients required extensive ablation to convert sinus rhythm. So at the cost of very expensive and also some other complication as well. So as Xian Chen mentioned, we should develop some way or some algorithm who patient go to the ablation first, or the single shot in the cryo balloon, or the very easy way, PBI only, and some patients more extensive ablation, some patients just upstream, as you mentioned, the correction of sleep apnea, and the correction of body weight, and other risk factor. And the others are to keep the rate control to just minimize complication as well. So we don't have the better solution, the better some algorithm to the treating the atrial fibrillation as well. So I think in the future, as you mentioned, AI or some other NGS may help. So what do you think? Do you agree in the NGS or the AI or your practice, those technologies may add something?
Yeah, absolutely. I mean, I think that we have a plethora of data. Where now we have data from the electronic medical record, we have data from wearable devices, we have data from internet usage patterns. The problem is not the generation of data, and we have genomic data as well. The question is what to do with this data. And a lot of the sheer enormity of the data makes it difficult for the human mind or individual physician to be able to analyze the data for the benefit of the patient. So we need new computing tools to be able to do that, and artificial intelligence, development of neural networks through supervised and unsupervised learning is really the future of that processing of data, so that we can use it to help diagnose subtypes of patients, to get better diagnoses and thus better treatments for patients.
Okay, great. Professor Ashley, what?
Yeah, I completely agree. And I think that just to say one additional point, which I think the challenge is, as Raj mentioned, is not the generation of data, it's there. And it's not the algorithms at the other end, because we have methods of finding patterns in large-scale data. The big challenge is getting the data into the form that those algorithms can be applied. And I think that our electronic medical records have not been set up with that in mind. They've been set up with other aims in mind. In the United States, billing is a common reason for installing an electronic medical record. Really what we need that data for is to be able to do just exactly as we're saying, to define patients better and give them more precise treatment. And I think if we can get better at wrangling data, we call it wrangling, to just try to get the data into the form that can be fed into the computer, then I think that all these benefits will accrue, and I think it'll be very exciting.
I see.
Xian,
would you
yes,
comment on that?
that's because I get some comment from our hospital medical oncologist, because we understand that currently most of the patients with carcinoma after the surgical procedure, not everyone take the target therapy. Then based on the genetic mutation, then you decide you will take the target therapy or not, because the target therapy it is a lot of money you must invest on the patient. That is similar to our cardiac procedure, because we are cardiologists. We always favor invasive procedure. That's like the oncologist. They favor the radiation therapy or the target therapy for those patients. But finally, they find you need to do the genetic testing to see it is effective after target therapy or not. So that's why I think we need to thinking about what type of patients we need to offer very invasive procedure for those patients, not everyone.
Yeah, and I think Xian Chen brings up a great point in the sense that when you have, this data and the neural networks and the treatment plan, we want to make sure that the algorithms that are developed from all of this data don't always favor treatment, but also sometimes favor watchful waiting. And that the biases that exist within our field don't start to infiltrate the neural networks and the algorithms that are generated from that data.
Yeah, and I think, that's a great point, and I think that there is an opportunity, because if we set them up correctly and get the data in correctly, we have an opportunity to overcome our own biases. We're all very much influenced by prior patients we've had, but we've all seen a few thousand patients. Imagine we can feed into a computer tens of millions of patients' experiences then the computer can derive insight and inference from that large number and actually be less biased than the humans are. But it's all about how we get the data in and how we build ultimately the algorithms have to be set up by a human, even though the power of the computer then comes later.
Okay, great. So we are today the short period of time that we discuss about some key word I think in the intercontinental. There is some ethnic difference, right? So yeah, intercontinental, I think in the precision medicine approach, and we have to develop some better algorithm to the individual therapy of the cardiovascular or the vascular or the cardiac, the arrhythmic disease. So today we learn we are very challenging about the heart failure program and the telemonitoring and the remote monitoring and also the gene analysis, discovering and the gene-based precision approach, and also the future of the electrophysiology, 3D mapping and the AI incorporation. So that's I think in the future, but we wish to have the intercontinental collaboration and also to give the more open platform to our next generation as well. So I'd like to thank all the three speakers and give us the great insight in the evolving and the emerging issue in cardiology today. Thank you very much.
Thank you.
Thank you.
Thank you.